Good afternoon, everyone. I would like to share my experience in tympanoplasty. Though a routine case for many ENT surgeons, but there are many ways to deal a central perforation. So my topic is mainly limited to type 1 tympanoplasty. It's an operation to eradicate the disease in the middle ear and to reconstruct the hearing mechanism. So in a CS1 we have central perforation where we have all the tympanic membrane all around, and a marginal perforation where the perforation may be near to the annulus. So tympanic membrane, as you know, it's a dimeric structure, pars tensa, pars flaccida, and if you can divide the tympanic membrane into 4 quadrants, and these quadrants are of major importance in evaluating the disease and also in planning the surgical procedure. So I draw imaginary line along the handle of the malleus and a perpendicular line at the umbo. We will divide the tympanic membrane into 4 quadrants: anterior superior, anterior inferior, and posterior superior and posterior inferior. Of all these 4 quadrants, the posterior inferior quadrant perforations are easier to handle, and the difficult ones are anterior perforations. So middle ear cleft comprises of middle ear, masted antrum, and the connecting iris addendum. So why I am dealing with this is the ventilation for the middle ear comes from the anteriorly through the eustachian tube and posteriorly through the iris addendum. So ventilation is very important for the good middle ear health. In the ventilation pathways, the critical part is the iris addendum, that is giving the ventilation from the masted antrum in the posterior part of the middle ear. So if these ventilation pathways are blocked, they may result in effusion of the middle ear, maybe if it is infected into an otitis media. So ventilation pathways needs to be respected if you want to proceed for a surgical procedure and you want to get a good outcome. So anteriorly via the eustachian tube and posteriorly via the tympanic isthmus. So this is the ventilation into the epitympanum as well. See here, this is the eustachian tube and the ventilation is coming and going through the masted antrum and behind, in between the ossicles like malleus and incus, and it is going into the anterior epitympanic space. So you always check your eustachian tubal patency. This not only important for disease prevention but also is having a surgical significance. See, in one of my cases I found the eustachian tube, there is some overhang or the eustachian tubal orifice in the middle ear. So because if you identify this, you can make it widen and you will have a good ventilation for the middle ear. So the principles of tympanoplasty, mainly the eradication of the disease, thereby you will create a dry ear, and if you restore the tympanic membrane integrity, you will restore the sound conducting mechanism. But if you don't maintain the ventilation pathway, this will again become a otitis media or effusion in due course of time. So maintenance of the ventilation pathway is very important, and also assessment of the eustachian tube function. So like I said before, the objectives of tympanoplasty is to achieve dry ear, improve hearing, and prevent recurrent ear infections. So for that, we'll have a good thorough preoperative examination. So as I said before, depending upon the site of the perforation, you can plan your procedure. If it is anterior perforation, posterior perforation. In posterior perforation, if the perforation is the posterior superior quadrant, so you must be careful. If there must be any coexisting retraction pocket. If it is subtotal perforation, maybe you should be very sure that you have tucked the graft on all sides of the perforation. So also I mentioned about the canal size. If the canal is very narrow or any awkward bounces or any bulges that are impeding the view of the annulus, so maybe you should also tackle the canal dimension, and also check for the pre-auricular and post-auricular region for any fistulas. So these are various types of tympanoplasty, but my talk is mainly limited to type 1 tympanoplasty, most commonly called as meringoplasty. So in the preoperative evaluation, we'll go with the routine surgical profile. Anemia should be corrected, less than 10 grams hemoglobin. Maybe you should not take up the case. Audiometrical evaluation. If there is SN loss, good preoperative counseling is a must. Yes, you can do a tympanoplasty even for SN loss patients also. If you give a dry ear, the patient can wear a hearing aid. But you should give a good preoperative counseling. In radiology, maybe X-ray massets are obsolete nowadays. A good HRCT temporal bone gives a good idea about the ossicular status and the disease in the middle ear and masthead cavity. When to advise CT temporal bone? Maybe not for all routine dry central perforations, but it always gives a good assessment of the middle ear and masthead anatomy and any ossicular chain abnormalities, masthead involvement, and also it will give a good roadmap for the surgeon to plan the surgical procedure ahead. So you are ready with the graft, and how do you want to place it? Is it onlay, interlay, underlay? So now we are used to do underlay since many years. Now a new technique, interlay, has come. So I will go through each and every technique and various steps. So this is the infiltration. We use 2% xylocaine mixed with distilled water, the 7:3 weight by volume. So make it 1% xylocaine, and for each 10 ml we add 4 to 6 drops of adrenaline, and we'll infiltrate in the post-auricular region 5 cc and each canal wall 1 cc each. So that makes 8 ml, and the rest for the eustachian for the around the temporalis fascia graft region. So you should have good blanching. If you get good blanching and good block like this, you need not infiltrate again in the canal. Just with a 10 cc of infiltration, you can do your mastectomy as well. So this is vascular strip incision in the external artery canal, one horizontal incision from the 12 o'clock to 6 o'clock, and 2 vertical cuts, one at the 12 o'clock and the 6 o'clock. So with a round knife, I am elevating the flap laterally. So after giving post-oral incision and harvesting the temporalis fascia graft, now I am proceeding for tympanoplasty. I have freshened the margins of the perforation. Now I am giving extended canal incisions. These are very important if the perforation is too anterior. So like I said before, the size of the perforation, site of the perforation, it all depends, and you can plan the canal incisions. So while elevating the annulus, gentle care is to be taken while identifying the chorda and delineating the chorda from the annulus and gently elevating it. So in this video I am demonstrating the underlay technique. So TM flap has been elevated. So this is the right ear, and the sacred annulus is, that means untouched annulus is between 2 o'clock and 4 o'clock. So I am skeletonizing the annulus. You can do with a sickle knife, curved pick. I am using a cup forceps for this in this case. So underlay grafting with a temporalis fascia graft with a slit in the superior region. The cut should be a little bit anteriorly, because it all depends upon the area that is available from the malleus to the anterior meatal wall. Pass the graft below the malleus, gently slide it. Yes, I have done the double breasting. Now I am repositioning the TM flap.
81441 ఉంది.
dry gel foam pieces are kept lateral to it. These dry gel foam pieces, they absorb the blood and act like a glue, and they will make the graft stick to the TM remnant. Now I am elevating the TM graft assembly and placing the dry gel foam pieces in the middle layer. These dry gel foam pieces, by virtue of their firmness, we can pass the graft laterally and anteriorly. So while sliding the temporal gel foam pieces also, you should take care that the curved pit doesn't touch the or injure the middle ear mucosa. And after that, place some wet gel foam piece, soaked in antibiotic steroid drops like ciprofloxacin drops. So to care of any inflammation. And after that, dry gel foam pieces, they call as gel foam tiling. These dry gel foam pieces, if they are made to press along the canal wall, they will make the skin and the temporalis fascia stick to the canal and make the canal wide enough. So this video about interlay. In this, as you know, tympan membrane consists of outer epithelial layer, middle fibrous layer, and inner mucosal layer. So here we will elevate the TM we will get a cleavage between the middle fibrous and the inner mucosal layer. See, I am elevating the annulus, and from there I am leaving the mucosal layer inside and getting the cleavage between the middle fibrous and the inner mucosal layer. By leaving the mucosa like this, the advantage is you will prevent mucosalization. This mucosa will act like a platform over which we will place the graft. The more gentle you have, the more time you save. So I am elevating the annulus anteriorly also. Malleus also has been skeletonized. Small dry gel foam pieces are kept medial to the mucosal layer. These will act some support. These will give some support to the mucosal layer, which acts as a platform for our upcoming grafting. So the steps are more or less the same for interlay and underlay. Only thing is we are getting a cleavage in between the middle fibrous and inner mucosal layer in interlay. So in underlay, what we will do is we will remove that mucosa and others if it is something edema or something like that. So in interlay, we are respecting the inner mucosal layer. As I said before, always inspect the ossicular chain. Little bit of curettage in the posterior superior quadrant of the bony external artery canal will give some idea about the IS joint, if it is intact, how about the mobility, so that you can be rest assured about the hearing improvement as well. Sometimes even in subtotal perforation there might be ossicular necrosis, or sometimes there may be even ossicular fixation. I mentioned about canaloplasty. So canaloplasty is four-quarter widening of the bony external canal to offer a good view of the complete annulus in a single view of the microscope. So canaloplasty is a must in some situations. So if there is a bony hump, you can get over with tilting of the head of the patient. You can tilt the table of the patient, and you can move like this or that way. But even in all these maneuvers, even if you could not get a complete view of the perforation, you should go for for canaloplasty. Never hesitate to do a canaloplasty if you are unable to see the complete view of the perforation, because this automatically improves the surgical outcome. In it also, you will be very confident about the graft tucking. So this improves visualization, and it also enhances the drainage. If the canal wall is very narrow and there will be a lot of debris in the post-operative region, post-operative period, and you will be very much worried whether the graft medial to it has taken up or not. So if it is a very wide external artery canal, you will feel very comfortable, and the graft also heals very well. This canaloplasty, of course, not just for the tympanic membrane perforations, it is also may be required for correcting any exostosis, any other prominent suture lines. Sometimes these prominent suture lines will create some problem while elevating the TM flap as well. Small video I want to share with regarding this canaloplasty. See here, there is a posterior bony hump, and I am unable to see the annulus completely. A slender conical burr is very well suited for this canaloplasty. While doing canaloplasty, many might worry about the facial nerve, but the facial nerve is very behind, and you need not worry about the facial nerve. But you should be watchful every time. Place a small silver foil to protect the TM flap. If you are approaching nearer to it, go for a small cutting burr, and if you are worried about, you can use a diamond burr. See, this is the view which you could achieve with a canaloplasty. You have a complete vision of the entire subclavicular perforation 360 degrees. When metoplasty, many people will think that it is for MRM cases, but in some cases where the meatus is very narrow, the metoplasty is also important. You have made a wide canaloplasty, but the meatus is very narrow. Metoplasty is nothing but widening of the cartilaginous part of the external artery canal. I mentioned about tympanoplasty, about tympanosclerosis. You should also observe while elevating the TM flap whether the tympanosclerotic plaques are just confined to the eardrum or they are in the middle ear as well. Why? Because if the tympanosclerotic plaques are more in the around the ossicles, you may not have good postoperative hearing. So that you should always examine. So see, in this case, there are tympanosclerotic plaques or the eardrum and also around the ossicles. So if you see this in preoperatively itself, you will advise the patient that you may require mastectomy, and he may not be having as good outcome as a simple tympanoplasty. So if you give a good counseling preoperatively, so you will have a good rapport with your patient. And also here I would like to emphasize the importance of preoperative video otoscopy. And about cortical mastectomy, many advise cortical mastectomy adjunct to a tympanoplasty. True, it's just a small 5 minutes procedure and you will have a good outcome, but may not be for every cases. For all dry central perforations, it's not at all required. It will be like this only if you want to do. Here the Yugofish water test is positive, so that means dilatus is patent. Small video about total annular excision. Nowadays this technique is gaining more importance. So when you are dealing with meningitis, weeping ears, you have a good graft assembly, you have done a graft take-up is also very well, but still the ear is discharging. So this is because of any granular meningitis. So there might be some mucosalization. So what you will do, you will excise the granular part of the tympanic membrane and you do a grafting if you want to do a revision case. In this total annular excision, apart from the granular part of the TM, you will also excise the annulus. This TAE technique you can reserve for granular cases, revision cases, or you can do it for all your cases. So the steps are same for before for all the routine cases. So see here, some spina fenley is prominent. You can drill this to make it regular and you have a good view of the perforation margins. So after trimming the margins of the perforation, elevating the TM flap, we will incise the post-metal flap in the center and we will excise the granular part along with the annulus 360 degrees. So you may say there might be blunting, there is no annulus, so how can the graft stays? So if you are doing a proper way, there will not be any blunting. I will show you how.
Is that the annulus you are doing?
Yeah. See, I am checking for the chorda and the ossicular integrity. You should respect the chorda, ossicles, middle ear mucosa. Again the same underlay double breasting, temporalis fascia grafting, and repositioning the TM flap. Gel foam has a very good importance. See, while placing this gel foam, I am pressing the canal skin into the annulus, into the sulcus of the annulus. So thereby will prevent blunting. So you could see there is no lateralization and there is no blunting. We are all microscopic surgeons. Now endoscopic surgeons are also coming. It is also a good technique. It is minimally invasive and we have enhanced visualization, and if you are happy with the procedure, and the surgery time also will be less, and moreover most important thing is there is a good faster recovery. The eardrum heals in just 2 weeks, just like a stapes surgery, because we are avoiding the post-auricular incision cornus flap, and we will harvest the graft in the superior incision. Depending upon the surgeon convenience, he can sit, stand while using the endoscope. Steps remain the same. Incision may be little bit medial. It will have a small flap that is easier to handle. Main problem with the endoscopic technique is you will be single-handed. If there is bleeding, you will have more troubles. So a good hemostasis, maybe you will wait for some time after giving incision, after giving infiltration. You will wait for the hemostasis to settle, then you will start the procedure. Frequent saline washes also improves the visualization. I feel in my experience the graft is little bit smaller. Smaller graft is better in endoscopic technique. It is easier to handle, one, and the other thing is the graft should not pop out through the incision. It should just come up to the level of the incision. This is my favorite hanky maneuver, where I use a dry gel foam piece and press it over the graft and the TM remnant. So thereby we will see whether it is equally good, well tucked all around or not. And lastly we will fill the external canal with the wet gel foam. In the post-operative follow-up, I'll give 2 weeks of antibiotic course and antihistamines, NSAIDs maybe for 1 week, multivitamins, and I will start antibiotic ear drops from the first week after removing the masted bandage. We should follow up the cases till 3 months, and if they want to fly, they can fly after 3 weeks. Thank you. That was very